Great, thank you very much. I'd like to also thank the organizers, although I am one of the organizers, so I'm sort of thanking myself for speaking with you, but it's wonderful to be here in Rome with everybody. And I'm going to basically take off from where Tom left off and look at some practical applications in molecular diagnostics, and you'll see a little bit of overlap, but some different perspectives on some of the same data that we have. And what I'd like to do is to begin with my summary and do it more as a timeline, because it really helped me think about this a bit, and my disclosures are at the bottom. Really, this explosion of molecular diagnostics and even prognostics and therapeutics began really with fine needle aspiration, which really has its roots back into the 1950s, but it's more in the late 70s and early 80s when it really became a tool that really reduced the number of unnecessary surgeries. And this is the single biggest effect on reducing unnecessary surgeries. And then we started looking at molecular markers, and I think one of the early molecular markers was galectin. And it's still being used at some places as an immunohistochemistry approach. Another one was telomerase, not what Tom was talking about, but actually the telomerase enzyme itself. And this was again in the mid-1990s. And then in 2003, it doesn't seem that long ago, was when BRAF, V600E, was first associated with papillary thyroid cancer. Now I'll pause here because I began doing these studies in the early 1990s, and like many other people at that time, I thought we were going to find the one golden bullet target. Galectin, telomerase, BRAF. But as we know, using BRAF as an example, the specificity of BRAF, meaning if it's positive you have a cancer, is excellent. The sensitivity of BRAF alone is poor because there are many thyroid cancers that do not have a BRAF V600E mutation. So it really took us to think more broadly and looking at sets of markers. And some of the early sets of markers around 2010 was Thyra Seek or Thyra Seek version 1. And this is the 7-gene panel, and I'll show more data on this. Afirma gene expression classifier. Now we're looking at an mRNA classifier, looking at many RNAs, starting out with the whole exome and working our way down as a model. And in 2013, so not all that long ago, was when it was first identified that there were mutations in the TERT promoter, as Tom talked about. The Cancer Genome Atlas for thyroid, papillary thyroid cancer, came out in 2014, and Tom nicely talked about that. The poorly differentiated anaplastic came out in 2017. That is, again, out of Jim Fagan's group. And then a lot happened in 2018. Our group came out with that very large study with advanced differentiated thyroid cancer and anaplastic. And then I put this in blue because this is a therapeutic tool here, Pax8-PPAR. And this is Ron Koenig, I'm on the paper, and so is Tom on the paper. Ron Koenig's group out of Michigan, and two things it really showed it nicely was that that's potentially a therapeutic target using a thiazolidinedione in a patient who has this rearrangement. Many patients with advanced thyroid cancer do not have this rearrangement, so it's pretty uncommon. And then, of course, the big breakthrough with anaplastic, having BRAF and using that as a therapeutic target. And then the Afirma gene sequencing classifier, which I'll talk a bit more about. Thyra Seek version 3, which I will talk a little bit more about. And then the last thing, which I won't, is the really big explosion with looking at RET, rearrangements and point mutations, and NTRK fusions as therapeutic targets. So we've really had a molecular explosion, especially since 2010. So as we know, the management of patients with thyroid nodules, we do the FNA. Again, that has really moved the field forward. And if it's benign, we can do clinical follow-up as a benign tumor. If it's malignant, we need a therapeutic thyroid surgery. Here we say therapeutic thyroidectomy. I would say thyroid surgery because now we're talking, as in this conference, about lobectomy. And then if it's indeterminate, we need to consider if we need to do a diagnostic surgery or not. The Bethesda cytopathology classification that you heard earlier, really I wanted to focus on what it did to indeterminate. We see here suspicious really is a higher risk of malignancy, follicular neoplasm, this range, AUS plus here, and this is the revised version, kind of the estimated ranges they have, and sort of what you can sort of do to change the management based on these subclassifications with Bethesda. So now with molecular testing, what we can do is basically take some of these indeterminates, and if we have a test with a high negative predictive value or sensitivity, that if it's benign, we can have the clinical follow-up just like a benign cytology. If it has a high positive predictive value and specificity, we can treat it as a malignant cytology and go to a therapeutic thyroid surgery, not diagnostic. So what about these tests? And what I want to do, and I think we all now know when we talk about negative and positive predictive value and sensitivity and specificity, if we want to compare different studies, we have to look at sensitivity and specificity primarily, because those are independent of the predominance of that, of the cancer in the population. And so this is the early Afirma GEC sensitivity and specificity, and the 7-gene panel Thyra Seek, and you see the genes down there. The GEC had a high sensitivity and not such a good specificity. The 7-gene panel had a very good specificity and not such a high sensitivity. So that led to what I would call the second generation of tests. The Thyra Seek version 2, now a 19-gene from a 7-gene to a 19-gene panel. The ThyGenX Thyromere, which is this panel that has 8 gene mutations, and then the microRNAs, and then a straight microRNA test, the 24 microRNA reveal that is no longer available, and you can sort of see the sensitivities and specificities there. They're improving. So the third generation testing I would talk about is, first of all, this Afirma genomic sequencing classifier, again, relying on RNA sequencing for the most part. Gene expression and now mutations are added in. It has a series of classifiers. Now is looking at over 10,000 genes, but 1,100 core genes for this, and also will call out BRAF and the RET rearrangements, and has a Hürthle gene classifier. We worked on the original GEC, and it was terrible for Hürthle tumors. This is much better for Hürthle tumors and is not overcalling nearly as much as the gene expression classifier did. What they did was to take the samples from the gene expression classifier study, that 2012 New England Journal study, reblind them, and then rerun them in this gene sequencing classifier, and you can see that it still retains a very high sensitivity and has an improved specificity from 52 to 68%. If we now look at it in context of the malignancy rate, the negative predictive value is very high here, and the positive predictive value is still not super high in this test. It also has what's called an expression atlas, where they can report out certain mutations based off of the RNA sequencing. I would like to see that a bit better validated, but that's, again, another nice tool that could be available. The other test is the Thyra Seek version 3 genomic classifier. This is 112 genes, a combination of point mutations, insertions, deletions, fusions, copy number alterations, and gene expression. You see the flow here with your sample. Obviously, if it's acellular, you would stop. If it's cellular, is it thyroid follicular cells or some other subtype? It can be called out as parathyroid, medullary, or inadequate. Then the next generation sequencing analysis is done for this genomic classifier, and we get these results here as negative or positive, and also the detailed mutation findings, which I find to be helpful. So this is the study that looked at this. It was a prospective, double-blind, multi-center study for this genome classifier, led by Yuri Nikiforov and first author Dave Stewart. And then each alteration gets a score of 0 to 2. So some copy number alterations or other genetic changes may have a score of 0. Some, like some RAS, have a score of 1. BRAF V600E has a score of 2. So that alone would make it high cancer probability. And just to show you in there, 60% of the tumors, nearly 60% of the tumors had a score of 0 or 1, which in this study is considered benign. So 40% were considered a high cancer probability. And what you'll see in a report is a score of 1 is currently negative. And I guess I'll go off of what Yuri talked about earlier, and I kind of teased Yuri and Marina about this. So if on a Sunday you're negative, and on a Monday you're currently negative, does that mean on a Tuesday you might be malignant? So we're still struggling with this. How do we deal with currently negative? I totally understand and have talked to them about this, but I must admit I still would like a different name for this. So this was 247 indeterminate FNAs. Bethesda 3 and 4 has a very high sensitivity now, which that 7 gene classifier did not, and still retains a high specificity. Not as high as the 7 genes alone, but still has a very high sensitivity with a high specificity. This study had a 28% malignancy rate, so a very high negative predictive value, and still a fairly good positive predictive value here at 66%. So again, if you look at all the studies, first, second, and third generation, you can see the sensitivities and specificities compared across there, and they've continued to improve throughout these iterations of these molecular tests. So now we want to apply this to patient care. And this is where we need to come back to negative and positive predictive value and use those sensitivities and specificities. And this is where disease prevalence is very important. So I'll show a few different lines here. One line is where the farthest out we can go, the highest risk of malignancy, disease prevalence, and still maintain a 95% negative predictive value that would be considered a reasonable rule-out test. And you can see both in Bethesda 3 and Bethesda 4, with that 95% negative predictive value, there's a very high positive predictive value. What about on the lower end that we see in these two different groups of risk of malignancy? Well, if you go down around 10% risk of malignancy in the Bethesda 3 category, of course you have an extremely high negative predictive value, great rule-out test. But if your institution where you're working the Bethesda 3 has a very low risk of malignancy, the positive predictive value is going to be lower. So if you get a positive test, that's going to be lower in this population. In Bethesda 4, similarly, you have a very high negative predictive value, down around 15%, which is the lower end of Bethesda 4, but again, about a 40% positive predictive value. So what this is saying is you need to know the disease prevalence in these categories at your institution or whatever pathology site you're sending this to. So we looked at that at the University of Colorado between 2011 and 2015, and this is over 2,000 FNAs, and Kelsey Deaver was the first author on this paper last year, and 11% were Bethesda 3 and 4% were Bethesda 4 in our category. And the malignancy rates actually for us with those were fairly similar. They were in the ranges of what we talk about, but they were both about 25%. What I thought was interesting is if we would have done 1 year, picked out any 1 year, this is what we would have seen. All over the place. So this is the Bethesda 3. It can be low, very high, lower here, kind of in that mid-range here, all over the place for Bethesda 4. So what we did was looked at a 3-year range, and so the overall range was quite high if we went from year to year, but a 3-year range looked pretty reasonable for what we think about here, Bethesda 3, and here, Bethesda 4. So I think two things we took away from this. You need to do a multi-year average if you're going to do it, or if you have thousands and thousands, if you have 10,000 of these, you could probably do it in 1 year. You just need a large enough number to get this. And so what we're doing at our institution is every so often we do a 3-year average to see what our malignancy rate is. And if you look at our range, that 3-year average range, this is where we would fall out for Bethesda 3 and Bethesda 4. Excellent negative predictive value and still a fairly high positive predictive value on both ends of that range. So really, it's a good test in both of these Bethesda classifications. Obviously, you saw this from Tom Giordano, and I just want to point out a few things about actionable targets. First of all, again, these BRAF, RAS, and RET mutations are mutually exclusive for the most part. And you also saw that there are TERT promoter mutations. There are some patients with these PTCs who have metastatic disease or more aggressive disease, but not a lot. And we see about a 9% rate of TERT promoter mutations here and less than 1% rate of P53 mutations. And we'll keep that in mind as we move forward. And then we looked again at Jim Fagan's study, Inigo Landa being the first author here in 2016, 84 poorly differentiated, 33 anaplastics. Precision oncology, you look at BRAF V600E, has that range of 30 to 45%. RAS, you can see 25, close to 30%, and RET, PAX8 is very low, ALK is very low. But again, if you're looking for those rare alterations that might be therapeutic targets, these are targets to look at. And again, TERT now, rather than being 9% like TCGA, it's 40 to 73%. And P53, rather than being less than 1%, it's 8 to 73%. So this really goes along with that more aggressive tumor that Tom talked about. And this, again, is just one section of our study looking at advanced papillary thyroid cancer with that same type of plot. If we blow it up here, we again can look at the mutation, the genetic alterations on the top. Numbers still are relatively low compared to other tumors and the different categories of alterations and pathways. And then we can call out the top genetic alterations here. This is papillary thyroid cancer, or BRAF. But next is TERT at 61% compared to 9% with TCGA. Again, this is papillary. Some would argue there are probably some poorly differentiateds in here. And then P53 is 10% versus less than 1% in the TCGA. So showing that these are very aggressive tumors. And again, with Yuri and Marina, what I've told them before is I'm getting ready for Thyra Seek version 4 because these are alterations that we found here that are not in Thyra Seek version 3 in papillary. These are alterations we see in follicular. And again, you nicely heard from Tom talking about Hürthle cell, which is a very different tumor, but we also noted some other alterations that are not there. So we may be seeing future iterations that incorporate some of these if, in fact, they help improve the classifier. So I want to finish with a little provocative patient story. This is where I think is going to be coming to a clinic near us. Exactly when, I don't know. 48-year-old female, 3 centimeter, biopsied papillary carcinoma. Of course we're going to take it out, right? It's 3 centimeters. Mike Tuttle, is he here? He wouldn't take it out. So if you did molecular testing, even though we heard that maybe RET PTC is in the middle, as far as aggressiveness, maybe this wouldn't be this alone, RET PTC rearrangement, we would maybe have a discussion with this patient on active surveillance versus lobectomy. And maybe would choose active surveillance, even in a 3 centimeter papillary. Good ultrasound, this is the genetics. If in fact this same 48-year-old female, neck ultrasound, no abnormal lymph nodes, no extra thyroidal invasion, we've got to be good with ultrasound, has this BRAF V600E and TERT promoter mutation, or as has been called by Ming Xiaojing and others, the oncogene duet, now we would recommend more aggressive therapy. Same tumor, same ultrasound, different genetics. And I think this is what we're going to be doing more of. People are doing it already now, but we're going to be talking about this and doing this more in the future. So with that, I'd like to thank you for your attention.
So yeah, thank you very much. Very brilliant and complete talks. And they are now open for discussion.
So should we come up?
Come on, guys, come. Yeah.
Do you have questions?
Did your change in your frequency of malignancy change with the staff of cytopathologists?
Yeah, I'll repeat that. So Dr. Giordano asked, did our change in the frequency of malignancy change with the staff pathologists? And the short answer is yes. And we did have one pathologist who left, and our AUS flush rate went down dramatically. So you got to have the right person leave to have that.
It's the obvious interpretation.
But it didn't, not over that time, that wide, the later years, later 3 to 4 years was the same pathologists.
Okay, over there is a question.
Brian, the gene expression classifier used to be the gene expression classifier used to be a rule-out test and the Thyra Seek rule-in test. But looking at Thyra Seek 3, negative predictive value is very, very high. Negative positive predictive value has come down. So the way that they look to me, both of them now, is good rule-out tests rather than rule-in and rule-out. Your comment?
Yeah, so my comment on that would be definitely those first generations, it was a flip-flop. You know, one was a great rule-out test, the other was a great rule-in test. What I would say now, both of them are great rule-out tests and pretty good rule-in tests, especially if the risk of malignancy in that population, Bethesda 3 or 4, is reasonably high, in that 20% range. If you're at an institution where it's 5%, the rule-in rate in either of those tests is not very good.
Okay, Rossella, yeah. available.
Okay. Okay. I have just a question for Brian. These new mutations that you found, 3%, 2%, 1%, and that you would like to add to the Thyra Seek of Yuri, are we sure that they are transforming mutations? Have been proven that they are really causing cancer? And if not, how can we trust to go further with the surgery, for example, only because a nodule has this kind of mutation?
Yeah, Rosella, that's a very good point. I don't think most of what we've seen, and I would let Yuri or Marina talk about that too, is I don't think they're drivers per se. I think what they are is they're things that can make the tumor more aggressive. One example I'll use is the cyclin-dependent kinases. And I think that's something that's associated with a more aggressive tumor. So it probably wouldn't help too much with a diagnosis because there probably are going to be other drivers there, but maybe it would help when we move this into a prognostic test.
Okay, thank you.
Other questions?
Thank you. Sorry. I want to ask about the BRAF V600E, if the allelic frequency can differentiate between the aggressivity of this mutation.
We looked at clonality very carefully in the TCGA study exactly for that reason, because there was this literature about clonality of BRAF being prognostic. We concluded that those driver mutations are clonal, meaning present in all the tumor cells. So we sort of refuted that literature. And I think that is in support with the pathology literature where you do immunostaining for BRAF V600E protein, and it's present in all the tumor cells. So, and it's almost, the thought is that these tumors are early oncogenic events, and the tumors are sort of addicted to these mutations. So I would say no. Yuri may have a further comment.
There's a question over there.
Possibly one of the aspects of this question is maybe not so much about BRAF, but like about RAS, about more like moderate level of mutations. When you find them in the FNA at lower or higher allelic frequency, does this increase the probability of cancer? No
In FNAs. See, that's so much harder because you have the sampling issue of how much normal the tumor do you have in an FNA, right? Maybe you can figure that out.
So what we find that for BRAF, really, any allelic frequency of BRAF V600E, it's 99.9% probability of cancer. There is no questions. But for other lower risk mutations like RAS, we do find that the very low allelic frequency more frequently is found in benign nodules or pre-cancer nodules, and very high allelic frequency in cancers, for whatever it is.
And I'm sorry, and Yuri, I think, correct me if I'm wrong, but don't you use, like in RAS, for example, that allelic frequency in your scoring paradigm?
Correct.
Yeah.
That's why really very, very low RAS, they read either negative or currently negative because exactly that reason. And I have also a quick question. Do you see now with the data on TERT that Tom showed and Brian also showed in several studies, do you think that we really have to start thinking about having TERT as a part of the routine pre-operative assessment of thyroid nodules before you take patients to the operating room? Maybe provocative questions, but I wonder what are your thoughts?
So I think, Ron Koenig engaged ITOG in trying to get a trial to do that, but it was challenging at best to sort of agree on a design. I mean, I think it would be nice to have a clinical trial to really show that patients, benefit from that testing.
Yeah,
Short of that, it's hard to mandate that testing, but I don't know, let the clinicians
clinicians
weigh in on that.
We have some preliminary data on that, and actually TERT is helping us to detect the patients that will have a worse prognosis. It's really helpful.
Yeah, and I think the issue I think with it is going to be is how common is that? Because that's what we tried to use something like BRAF before in these AUS plus or something, and it's a lower frequency mutation. And I think I would expect in a Bethesda 5 or 6 that a TERT promoter mutation would probably be about 5 to 7% of those. And I guess the question is that sufficient to add it as a prognostic indicator? And it might be. It might be.
Okay, last question, I think, over there.
Hi, I'm Amir Afroge from South Africa, and I had a few questions. First of all, it's actually good to know about all these fancy tests, but how the percentage of the population in America that these tests are accessible to them, how are they, and what is the price of these testing? And are these tests going to be available to other countries in the world? Because I know that Afirma has kept its concoction quite only limited to America, and I think it was given to Canada recently, and the Canadians published their experience. What is it for other countries like us, like South Africa? I mean, when are these tests going to be commercially available at a reasonable price to everybody, you know?
Right.
I could answer the third one. I have no idea. You know, I don't know if because I know there's some changes even with the Thyra Seek test on where the ownership is and things, but you're right, the Afirma GSC, it's proprietary and they run it in San Francisco. And so but I don't know where. In the US, many patients, this is covered fairly well by insurance, by Medicare, by Medicaid, and by private insurances. So it's covered fairly well. And they have plans where if it isn't covered for a patient, there's a certain out-of-pocket, I think it's up to $300 for both tests, out-of-pocket costs.
You know, I can comment. So I'm working with Giovanni Tellini to make a version of a test, because we do some research things with an Ion Torrent platform, and Giovanni's interested in developing an inexpensive test that can be deployed in Italy, recognizing that these other tests are just not going to be really commercially viable. So I think each country has to figure out, you know, the path forward. But, you know, we're going broke in America over healthcare, so maybe you shouldn't follow us.
Thank you.
I have a technical question. Yuri and others, you know, in the age of RNA, in single-cell RNA sequencing, at what point might whole exome sequencing and RNA-seq and replace the targeted panel approach at FNA? Is that something you might envision?
Yes, but it requires much more cells that they usually give us in the FNA.
Yeah, so the limiting, but you know, I'm flabbergasted when I see these single-cell sequencing studies, right? So the technology is moving forward. It probably will come at some point. Well, you just, like Brian's suggestion, to look for more mutations, we'll just get everything. Almost everything.
The only thing I can say is that, yes, I mean, but again, the question is how much cells we are going to get from the FNA samples. And if they give us sufficient number of cells, we can do exome and transcriptome. Tom, but the question is it will not be cheaper. I think that...
No, it'll be more expensive.
Exactly.
Right.
I think the point is that we need to find the way to use technology to bring the cost of the testing down so it can be really widely available, not so expensive.
Yeah. So everyone, I think that this is a great discussion. We're running way into our break that you had, and I want to make sure people can get some espresso. So thank you very much for an excellent panel.